Bismillahirrahmanirrahim. In this video, we'll discuss how to manage vitamin K antagonist in perioperative setting, one-page approach. And we'll start by illustrating the general rule of management of patient on warfarin. The general rule is depend on the balance between the bleeding risk and thrombotic risk of the patient. So the patient undergoing surgery with minimal bleeding risk, we will continue warfarin without interruption. If the patient have a moderate bleeding risk, we will discontinue warfarin 5 days before operation and restart warfarin again at day 0 and overlap with no molecular heparin at day 1. In patients with high bleeding risk, we will discontinue warfarin 5 days before operations, and again we will restart warfarin at day 0 after surgery, but at that time we will overlap warfarin with no molecular weight heparin at day 2 or 3 till the INR reach 2 or more than 2. But what about the part that during interruption of the warfarin? We may add low molecular weight heparin during this time. This is called bridging, and this depends on the risk of thrombosis. So in general, the management of low vitamin K antagonists depend on the balance between the risk of bleeding or risk of the surgery, risk of bleeding during surgery, and the risk of thrombosis, which depend on the patient risk. So what is the example of the bleeding risk in during surgery? Bleeding risk classified into minimal, low, or moderate, or high. For example, surgery with minimal bleeding risk, like for example cataract surgery, or insertion of pacemaker or cardioversion. Surgery with low to moderate risk of bleeding, like lap cholecystectomy, for example. Surgery with high bleeding risk, any other major thoracic or abdominal or bowel resection or cancer surgery or spine surgery. This is an example of the bleeding risk of surgery. What about the thrombotic risk of the patients? The thrombotic risk of the patients depend on the three categories, either the mechanical valve, atrial fibrillation, or venous thromboembolism. In each category, the patient can be classified into high, moderate, or low risk. And I will give example in high risk in each category. For example, patient have a mitral valve, either cage ball valve or tilting mechanical aortic valve. This is called high risk of thrombosis. Or any other mitral valve with prior stroke or valve thrombosis, or any mechanical valve with recent stroke or TIA less than 3 months. All these categories considered high risk of thrombosis. In patient with atrial fibrillation, he or she considered to be at high risk of thrombosis if the CHA2DS score exceeding 7 or patient have a recent stroke or TIA. In patient with venous thromboembolism, if I have a history of venous thromboembolism less than 3 months, or patient have an active cancer with because these patients have high risk of venous thromboembolism. This is an example of the high risk of thrombosis. Let's take some examples to illustrate how we can adopt this guideline in our decision. We start by patient with 65 years old male patient have an atrial fibrillation with recent stroke. The patient has on warfarin and the patient undergoing cataract surgery. First of all, we assess the risk of the bleeding. Cataract surgery is a minimal bleeding risk. And according to this guide, minimal bleeding risk, we don't need to interrupt the warfarin. So we will continue the warfarin without interruption. This is the first case. The second case, patient 65 years old male patient has an atrial fibrillation, CHA2DS score is 7, and the patient undergoing lap cholecystectomy, laparoscopic cholecystectomy. So what is the bleeding risk of the laparoscopic cholecystectomy? It considered moderate bleeding risk. So because the patient have a moderate bleeding risk, we need to discontinue the warfarin 5 days before operations. But what about the risk of thrombosis? The patient have a CHA2DS 7, this patient have a high risk of thrombosis. So during interruption of the warfarin, we need to overlap this time of interruption by low molecular weight heparin. So this patient need bridging. Last thing, we need to restart warfarin at this part at day 0. And because this patient have a moderate bleeding risk, we may add low molecular weight heparin at day 1. Let's take last example, the 35 years old male patient, DVT 1 year ago, the patient on warfarin and undergoing colon resection. So the patient on call, because he a patient undergoing colon resection, this is a high risk of bleeding. So we need to discontinue the warfarin. So this patient in this category, high risk of bleeding, will discontinue our warfarin 5 days ago. The patient have a DVT had DVT 1 year ago. So we will this patient have a low risk of thrombosis. So this patient have DVT 1 year ago, low risk of thrombosis. This patient doesn't need any type of bridging. So we will discontinue the warfarin without adding low molecular weight heparin. Last thing that we restart warfarin and day zero, but in this example, we need to add low molecular weight heparin maybe at day 2 or 3 because these patients have high, this operation have high bleeding risk. And for further reading, you can check this guideline that recently published in CHEST 2022. Thank you.